Thank you. Thank you very much, Peter, for these nice introductions. And I would like also to thank the organizer for inviting me and Peter for giving me the opportunity to come and address such a distinguished audience. Today, I'm going to just tell you about our experience and share with you what we've learned in the field, because we've been deployed now for 1.5 years in Guinea. We've been involved at the very beginning of this outbreak, and I'm just going to talk about the experience. For that, I'm just going to give a little bit of background of Ebola virus. I'm sure most of you do not need it, but just to focus on key aspects to understand what is the situation now and what are the lessons that we can take from this outbreak, and particularly talking about Guinea, because Guinea is a good case study in the sense that it started there. It's probably going to be the last country to get rid of Ebola and end up with few take-home messages and conclusions. Now, just when I talk about Ebola, I really want to share this slide, which usually actually link Ebola with art. And I like it because this painting has been done by Henri Rousseau, who was in French one of the masters of what we call naive arts. And he never left Paris, but even though he never left Paris, he was really keen on doing all these tropical forests. And in this tropical forest, he imagined one of these women. And you can see how striking is this with Ebola, with the help of our imagination. And I just mention this because Ebola is a lot about talent, is a lot about passion, and is a lot really about making things happen through our imagination sometimes. Having said that, I just want to come back a little bit into history. Most of it actually has been done with Peter's help and different people. But what I just want to mention from the first outbreak in Yambuku, there were actually another area which was in Sudan, Zara, but in Yambuku in 1976. And if you look at, if you go through this outbreak, what you can see there was some people, foreigners that really died that have major impact. That's probably how Peter and different people got involved. And also from the first outbreak, we could actually know some very important information, how the virus was transmitted through injection, so transmitted by bloodborne, and also by implementing measure of protection that you can see in this hospital where people would wear some protections, and also being sure that they actually sterilize the different syringe, they can get rid of this. And actually in Sudan, what was interesting is this is the family of the first case that died. I show here this Ebola actually river that many of you probably haven't seen much. And what was interesting in Sudan is that this happened in this cotton factory. And within this cotton factory, you could see in one of the rooms where the different cases actually that were linked together, you could see on the roof that there was some actually dejections from bats. And those dejections actually give some clue about what was potentially actually the reservoir. So what I'm trying to say here is just based on this very first one, we have the stage actually that was really set in terms of information, how to protect, how the disease is transmitted, what can be the potential reservoir. And this is very important to keep in mind. But even more important, these actually outbreaks have a major impact in terms of emotions and in terms of societal impact. If you see that there was high lethality, 90% of the people died in Yambuku, 60% in Zara. And this turned out to be one of the deadliest viruses on planets. And this is associated with our mind. Scientific paper titled Death Called a River. And altogether you have some people actually that work for actually health that die out of it, most of them, and also some none that die out of it. And this is very important in the collective mind in the sense that people that actually are the ones that are supposed to cure death somehow are hit by this disease, and also people of God also are hit by this disease. And you can see how this is really impactful in terms of generating fear and panic. A little bit later, there was some outbreak actually that happened in Virginia, in Reston, where Ebola has been found actually from shrimp that has been actually imported from monkeys from Philippines. What was interesting about this is that actually they detected it happened twice, nobody got infected, but it showed that a virus that was so deadly could be very, very close to the White House. Virginia is a few miles from the house in the middle of the US. And this actually triggered a lot of the imagination of the people. You could see that these books, based on some true facts, and actually are really impactful in terms of telling a terrifying true stories. A movie actually done by award-winning César and all these people, Oscar, that winning having this outbreak, make all the collective imagination of Ebola. And even another, actually, movie that was not related to Ebola came to it. But all you can see through this is it talking about truth somehow and talking about fears. And this is very, very speaking like nothing spread like fears. And few years later, now what you have CNN saying about the first case of Ebola in Diagnostic, meaning that we move from actually what was fiction, turning to something that is a reality in the US. And you could see this New York, actually, the scare going on. And same in the newspaper, you would see in West Africa about deaths concerning Ebola. People should pray. While helping with Ebola, you can die. And also the major political issue about Ebola, lack of cooperation at the very beginning of outbreak, people were quarantining. I'm just saying this because this is important to understand what happened and how this went out of control. Now, what can we learn from the different outbreaks before, besides Yambuku and this first outbreak? This outbreak was associated with high fatality rate, most of them. There were 4 different virus, actually, lineage, actually, that was isolated in this different area. But there were not really much deaths. Ebola is not a public health really issue. Up to the 2012, when you have actually 1,600 deaths, roughly. And what happened then in 2014 was very important. But before going that, you just need to understand quickly how Ebola is working. First, it goes from the jungle. We suspect bad, but obviously, as said by Pasteur, we need more to know more. And from this, it usually introduced into human populations through usually hunting or activities has to do with food most of the time. And when it gets to the house, actually, it moved to different areas through actually people attending patients, through funerals, through sexual intercourse, and also people taking care of the patients and in contact with the fluid. It's very important because, as mentioned earlier by Peter, it's important to understand without close contact, Ebola is not an issue. And when it infects people, it can go through different fluids. And as mentioned earlier, one of the fluids that really is the semen, where you can see now, in this slide made by Pierre Rollin, it was about 3 months, but now we know that for 9 months and maybe longer than that, you can have Ebola. And through this, people can get infected. And that's really important when it comes to strategy and to make sure that when people actually are infected, we make sure that we isolate them the earliest possible. Because the earlier you isolate them, less are the contact they can have and less transmission happen. In addition, actually, they may have a better survival time because Ebola go to actually dehydrations and they have, the earlier they can take care and the better is the situation with that. So all the strategy of WHO most of the time is to focus on identifying case, having good contact tracing, and from there do management for clinics, and have a very, very good people working with social intervention to make difference, and also working logistics. Now, if we look at the timeline of events that happened in 2014, 2015, you could see that we arrived in Conakry around actually 23rd of March. A few days after we arrived, actually we diagnosed Ebola in Conakry. It was done before in Gekedu, like the forest Guinea. And few days after that, we diagnosed actually Liberia. And what you could see is that even though it was known here, nothing much really happened until later in May, and things really at this point reached some inflection point where you would see a second wave of Liberia. And you would see this relentless tide really mounting, Nigeria, Senegal, Mali, and in between you have United States that has been actually, Spain and United States later that got infected. And what this is telling us is that the delay that happened here, to which I'm going to be referring very shortly, has been really, really extremely important. Because while we are trying actually to get the virus here, things was actually spreading everywhere. And I think that's what makes it really complicated, this outbreak, because it turned out to a health problem that used to be handled at a local level to a massive logistic operation with implication in politics and economics. And this is very important because it reached all different countries, more than 28,000 cases and more than 11 deaths. And it's interesting to study the case of Guinea, as I mentioned earlier, because you could see in Guinea, if you look at the epidemic curve, that the first phase was what we can call business as usual, where you would have setting up like a treatment center, making sure you know your contacts. And from there, it moved to a phase where really we need to adapt all the strategy. And now we are at the end of this outbreak. We're trying to get zero, and this is kind of painful. At the beginning, I'm not going to mention too much about it, but Peter said already, it's starting in a region which is at the border, where you have cases going to different places. And this is the letter I received from the Minister of Health of Guinea through WHO. They were talking, when they addressed to me, that they have 46 cases. 28 people died. At that time, they didn't have a diagnostics. And they could not actually send any of the samples to my lab that is supposed to be the regional reference lab for this. And this lasted almost for 2 months. And this makes a huge difference. So if you have a lab in that place, maybe the situation would have been different. And the very important lesson we should take this is, first, we should focus on local real need. And the second, we are really as weak as the weakest link. If actually the weakest link is one of these countries, then it can go straight away and come to countries like United States and somewhere else. So if you look at the epidemic in Conakry, actually it's been introduced from actually funeral here, came to Conakry, and through different ways were introduced. So we're very interested about understanding how the virus has been transmitted in that area, because we get samples from all these different areas. And what is actually symbolized here is a different transmission chain, where you have the first one here that was 12th of March. And you would see from that case that people got infected actually either through funeral, you would see here in green, or through like hospital transmission, or through the community. And from there, you can trace the different, between March and August, a different transmission that happened. And what you could see, if you try to see that in terms of where things happen, the community was number one. The second was hospital, and the funeral was the less important one during that period. And if you try to map that over time, at the very beginning in March, the community was top, the hospital, and then you had funeral. But over time, these, as soon as they set up a treatment center, some interventions start happening, we have actually the decrease of the other different transmission mode, but the community was still very important. So the action in the community was something extremely important to understand at this first phase of the outbreak. And you could see here that in March, definitely the community was very high if you look at them. And over time, while people actually set up measures like treatment center, implementing infection controls, doing more social mobilization, things get better. But it could better in July, when the community start actually relaxing in May, then you would have a little jump over actually the transmission of this disease. Now, the impact of those interventions, what you could say in March is that whether you're talking about healthcare worker or non-healthcare worker, in the community it was high, but particularly among non-healthcare workers. And healthcare workers, because in Guinea, actually, they all have some clinics in their own house, some private clinics, where they see patients. So many of them got infected that way. And in the hospital, you have both of them that was kind of equally infected. The funeral, where you have mostly people from the community. But if you look a little bit later, from April, what was the situation? In the community, the people that was hospitalized obviously did get more opportunity actually to transmit, while the people that were not hospitalized through community deaths or late identified was actually the major people that was diffusing, while in hospital and funeral things were really under control. What is important about that is that if you look at this situation, sorry, I just forget to mention this, based on this sort of information, we did some simulation. And what came out of the simulation is that if actually we increased 10% hospitalization, we could have reduced the transmission by 26%, meaning that the timing is the important thing, as said earlier, Peter, but also making sure that we isolate people were very important. And that's also some basis of the WHO strategy to build and bury, what they call build and bury strategy, where they build all these treatment centers, train people how to bury, make sure that infection control is actually going on. And then the situation started really exploding in Guinea in August. And you would see at that time, things was really skyrocketing. And this was where we have this second phase, which was the phase where people really need to adapt and bring something new with this new treatment, with this new possibility to implement diagnostics after this public health emergency. What was very important in that period was more like opening a Pandora box, because every single day we would have something different. And we just left with hope. And this was very, very important in the sense that one of the first things that we have to tackle was really actually resistance of the community. Here you see the mapping of the resistance of the community. They would refuse to go to a treatment center because they believe that they will actually get their organ taken. People would tell you, I didn't sleep because if I sleep, they're going to take my organ. They don't trust the system. And where you have this resistance, they would fight people that are trying to help them. Where you have this situation, actually, you would see exactly that's the area where actually Ebola was really affecting. And some situation like that, having some riot in some countries, was really this sort of situation where people would die in the streets and having all the people around. This was really a major actually impact in terms of how the outbreak spread. And in this regard, you could see here we map in Guinea different resistance that happen. And over time, you see this resistance in different areas that tend actually to go and lower a little bit over time. And what, in this regard, it has been extremely important that the anthropologists and the people from social science help a lot in trying to understand. And what actually they put us and make us very aware is the fact that we really need actually to make sure that people are close to their family, they're not transported, they don't want to be in the treatment center because they don't have contact. And this actually pushes us actually to change a little bit our strategy for diagnostics. We actually designed a diagnostic system, which was in the field format, where we would have a glove box like that we can take in the fields, and we have some lyophilized mix, and also we have a quick extraction systems that was powered by solar panel, and we could take these thermal, the isothermal situation to the field and make it work very easily. And this changed quite a lot of things, because in the lab it looks like that, and all this you can pack them and put them in a car, and it has a major actually talks about this because it was short and it was at a period that was very important. But what you could see in the car, this is what the labs look like. And here is all we have in terms of solar generators. And this you can deploy it and put it together and bring it and work with it within like half an hour. You can get your diagnostic done, and you can set up in half an hour. And this was important in the sense that it was like more like homebrew innovation, trying to solve some problem. And this was very quick, and this is very important. From the evaluation that we see, it was 100% sensitive and specific on saliva, and that's why we use it actually to make sure that before people get buried, we have a diagnostic very quickly. And this was really appreciated by the team that was in charge of safe and dignified burial. Some other thing we are very interested also to work on, to try to understand was actually what was the situation with these 700 patients, how the viremia could be used as a prognosis, because there was some data showing in limited series that actually the viremia is very important in the outcome of Ebola. And by analyzing around 700 patients, what we could see that is as long as the viremia is less than 10 to 4, you have the probability of death was less than 25%. If it goes higher, what we call intermediary, actually it can go up to 50%, and higher than that, your chance was more than 75% of deaths. And this was some result that was very important, and that is coming pretty soon in publication. Even more than that, we try actually to see over time the case fatality rate if you predict that based on the viremia that was happening. And we see quite nice correlation. If you look actually only viremia, it's in blue here. And if you put some other parameters, the full model actually is also quite good, but viremia is probably one of the most important contribution, making this an interesting predictor and very strong one. And what you could see that over time, from March up to February, where we have really these major things going on, you could see that if you look at the profile of the patient, most of them would have low viremia at the very beginning. But the more we're going to this very difficult period, the higher was the viremia or intermediate. And this was kind of reflections of what was happening in the surveillance system, which means like people were really focusing on the civil one, trying to get them because they could not cope with all the different patients in terms of contact tracing. And that's exactly what I showed you earlier, the same transmission chain, but what you can see here during the period of September and to January is that you have more and more only yellow dots, which are people that actually, for which you couldn't link them to anybody or death community, meaning that the surveillance system could not actually cope with that. And all the different transmission community, hospital or funeral were represented in this. And if you look at also the different chain that was happening during that period, actually you could see that most of the chain could not really be quite long in the sense that it was difficult for the surveillance system to cope. And it's really, really important to understand that when it comes actually to the field, it's definitely important to see what is happening, what are the contacts, and how they relate to each other. And here we try actually to map and understand what was happening in terms of getting infected on some place and moving to another district. For instance, if you look actually this chain, most of them here were infected in the same district. But if you move them from district, you have some some people that move from this area and go to the other area and create a second chain of transmission. And the movement of people also has been extremely important during that period. And we could see that by doing some very detailed phylogenetic analysis that was published recently in Nature, where you could see actually in Guinea, you have in the forest Guinea, only two major actual lineage that was circulating. The Guinea one that was in red here, that didn't actually leave much Guinea, but you have the one that went to Mali, and also the one that went actually to Sierra Leone through this phylogenetic tree. This was the initial ones, and then it generated the Sierra Leone, and you have other in Guinea that was generated. But what you can see here is that out of Sierra Leone, you have actually the lineage that came here and got reintroduced in Conakry. So this was a major way where Conakry got infected, and we found this out by analyzing those different viruses that was circulating in Conakry and the area. Now, having this good mapping, understanding the role of community engagement, the role of the transmission, and also actually the role of the phylogenetic analysis leads us to this third phase, which was more like getting to zero. And what you could see here, if you look at Conakry, most of the Guinea, most of actually the outbreak was happening during this period from Forest Guinea, and it went straight to this end of to Conakry and the area at the end of this outbreak. And this is now where the fight is. And you could see that Conakry, if you look at the number of cases over the 15 days, you could see that Conakry move as a wave. People get introductions. When the virus is introduced, it generates actually new outbreaks. And this is really the way that things should be handled and understood for Conakry. If you compare that with Forécaria, where actually at the border with Sierra Leone, where the virus is happening, you have more a larger wave that would actually mimic the fact that we have a constant entry of the virus. And the only difference between these two places are the number of introduction. So handling the introduction, making sure where they come from, trying to control is the way to go for this ending this outbreak. The hospitalization was quite similar in the two areas, if you look at the hospitalized versus the non-hospitalized. Now, the focus is in this area, Forécaria and in Conakry, where people are actually at some point where actually they would do some very thorough surveillance, making sure that how people enter, and make sure that through very detailed sequencing, you can have a good idea about the transmission chain. So altogether through this outbreak, you have this first phase then, where that was mostly about behavior, having beds and burial. You have the community ownership that was very important in the second phase in the case finding. And now what is really, really critical is the survivor, how to support them, how to screen them, how to make sure there is no reactivation. And in this regard, actually, if you have to look in terms of future, we can look at this Margaret that I like, and which is one of my boss' favorite pictures, where he's actually drawing the future but having in mind what is the origin. And that's what we need to do when it comes to Ebola. Really think where things happen. The few take-home message is that this outbreak in term is unprecedented magnitude and very high complexity. It started with a health crisis, turned into politics, economics, and humanitarian crisis. The second important thing, understanding the driving force is important. In this regard, the transmission is key. Even though now we got the vaccine that helped with this ring vaccination, it is critical to understand that the population mobility, the patient profile, and also the community engagement, which is very, very important. In terms of research, it's critically important, actually, to support the innovative diagnostic and the case management, a lot to do. Vaccine and treatment, obviously, for obvious reasons, and social science. I really want to emphasize that one, because it's absolutely important that we understand how the virus works, but how the communities works to get all these solutions and use them is even more important, and this is one of the major lessons we learned from Ebola. Now, one important take-home message is that preparedness is critical. If you get the diagnostic maybe 3 months earlier, it would have made a difference. So getting ready where it is needed is absolutely important. And looking at the next rate, if you do some calculation, you can show that right now, we know less than 1% of existing in the zoonotic pool. And this is something that we have to keep in mind. The other important thing is we really need actually to focus on local needs in terms of infrastructure, resource, community engagement. And this is absolutely important. Whatever we do here in the US, in all these developed countries, without a very strong critical mass down there to the research, to the public health, may not be sufficient to help. And in this regard, obviously, relevant partnership is very, very important, and cooperation. And I'm happy because I got a lot of opportunity to actually cooperate with Gary Kobinger here with Rob Fowler, that has been very helpful. And here is the ELISA on which we train people in Guinea, and that is beginning since the beginning of the outbreak. This has been provided by Gary from the beginning of the outbreaks. And also we spend a lot of time training Guinean. We arrive as a team. Now only one of the people is supervising them. Most of the work is done by Guinean. But this need to find a way to be sustained and have a local expertise. And I think it's important also to be optimistic about the future. And for this, I really want to pay a tribute to Peter, because I think he's a great illustration of what Winston Churchill called an optimist. And optimism is really sees as someone who sees opportunities in any difficulties. And I think that's what Peter has been doing. When he went to Yambuk, he was 27 right here. And when he went back for HIV also, he has been really seeing opportunity in difficulties. And same when we took UN-AIDS. And I think it's a great pleasure for me to be here, because now he's getting this Gardner Award in 2004. And being optimistic is also about the future, is somehow, this is a illustration of what my family gave me while I was going back and forth actually to Guinea. This was my 50s. They gave me this painting. And in this painting, they were saying, okay, look, this is an eye watching, a family which is in the dark, threatened by a virus, and where you guys scientists are bringing the light to help them with Ebola. So, and they called me, Daddy, this is a way for us to support you, and this is very important to support the scientists locally. Now, just message of these survivors are doing fantastic works. And these two people, actually, these have been taken by Rob Fowler, are now, they lost all their family, and they're still working with Ebola. And also these fabulous pictures about that young lady that was having these thank you for science for the vaccines. So I just want to thank all the different people that has been working in my lab and the team in Conakry. Thank you very much for your attention.